cancer, the disease that haunted the humankind for years. According to cancer registry data of WHO, the Global Cancer Observatory, for the year 2020, where the total population of Malaysia is 32,365,998, there is 48,639 new diagnosed cases, and caused 29,530 deaths, just for the year of 2020. There are many types of cancer treatment which will depend on the type of cancer that having and how advanced it is. The treatment choices include surgery, radiation therapy, chemotherapy, immunotherapy, targeted therapy, hormone therapy, stem cell transplants, biomarker testing, and some of the treatments that are still under clinical trials. Some people with cancer will have only one treatment, but some will have a combination of treatments, such as surgery with chemotherapy and radiation therapy. Almost all of these treatments need a long period. What if I tell you there is an option of choice that may help to shorten the length of treatment period? Its name is IORT, Intraoperative Radiotherapy. This video going to tell you what intraoperative radiation therapy is, how it's used for breast cancer, some of the potential advantages and also the possible disadvantages and concerns about IORT. Also, there are some of the qualifying features about breast cancer. They may let you determine whether you are a candidate for IORT. IORT refers to the delivery of a single large dose of radiation to a limited volume of tissue during a surgical procedure. It has the capability to increase the radiation dose with very limited or no increase of toxicity thanks to the target exposition during the surgical procedure. For this reason, IORT can be used in various settings of gynecological and genitourinary tumors, even tissue sarcoma, aiming at dose intensification and consequently at increasing tumor control rate. IORT can be delivered using dedicated linear accelerator producing electron beams, X-rays sources delivering low-energy radiation or high-dose rate brachytherapy units through catheters positioned in the tumor bed and loaded with iridium-192. The current standard care for breast cancer is breast-conserving surgery followed by whole breast external beam radiation therapy, which eradicate residual tumor cells. Patients receiving external whole breast radiotherapy received 45 to 50 gray of radiation in 25 fractions over 5 to 6 weeks, followed by a booster of 10 gray in 5 fractions. While IORT is an accelerated partial breast irradiation technique delivered at the time of lumpectomy. When someone has a lumpectomy during surgery, the IORT is planned in advance with radiation oncologist and breast surgeon. During the breast cancer lumpectomy, the surgeon removes the tumor with a good margin normal tissue around it, and the radiation oncologist comes in and places the device for about 30 minutes, while the patient is put under anesthesia in the operating room. It radiates the area where the tumor was to kill any cancer cells that might grow in the future. It would call that a recurrence. IORT can be carried out in two approaches, which are the targeted intraoperative radiotherapy, delivering low-voltage X-rays of 30 to 50 kV directly, and the intraoperative electronic radiation therapy using large-dose electrons, 3 to 12 MeV. For both technical IORT approaches, two different treatment concepts are proposed: IORT as full-dose partial breast irradiation or IORT as anticipated boost followed by whole breast radiotherapy. IORT has manifold advantages such as giving radiation therapy to the well-vascularized and oxygenated bed of tumor, the limitation of tumor cell repopulations, reduction in cytokine production, giving a minimum dose of radiation to adjacent organs, and patient convenience. As IORT irradiates the tumor location directly during breast-conserving surgery, so it can ensure the accurate positioning of the tumor margin, site, and the accuracy of radiation dose. Different diameter tubes can be selected according to the size of the tumor and the area of tumor bed, to make tumor site get high-dose irradiation and protect the healthy peripheral tissues. Thus, IORT significantly reduces post-operative radiotherapy complications such as pulmonary fibrosis and skin contracture. There are usually 4 to 6 months between surgery and traditional adjuvant radiotherapies. During this interval, adjacent lesions in tumor beds may proliferate, while IORT can avoid this interval, thus reduce local tumor recurrence. Also, a single high-dose intraoperative irradiation can effectively destroy the tumor microenvironment where the tumor is located, such as reduce microvessels, change the recognition and killing effect of immune cells on tumor cells. As IORT is given at the time of surgery rather than a 3 or 4 week course of daily doses of traditional radiotherapy, patients are able to save the time taken to travel to a radiation center on daily basis over a long period. And if you live a distance from a radiation center, that time commitment is very significant. Thus, IORT is more economical and time-saving. IORT technique may result in tissue fibrosis and necrosis in long-term follow-up. More attention to the fat necrosis and incision calcification of patients after orthovoltage IORT treatment is needed. Besides, IORT did not significantly alleviate the patient's pain in their assessment of persistent pain after radiotherapy. IORT is an accelerated partial breast irradiation technique, carry the risk of overlooking peripheral tumor beds or areas outside the target volume. The main causes include the proximity of the tumor to the skin and the oversize of the target volume. Also, it is a rather new technology. IORT has had trials, but not yet out for a long period of time to really calculate what the local recurrence rate is over the long term, but the local recurrence rate is just a couple of percentage points higher than whole breast radiation. In present study, IORT, as a boost dose, does not show a significant difference with EBRT in terms of disease-free survival and overall survival. Doctors have been debate and argue about it at breast cancer meetings all the time, so it's a rather controversial subject, but in general IORT has not been deemed to be as effective or equal to whole breast radiation, but there's a small difference and it's really up to patient's choice. Different countries and organizations have different indication of IORT. To this date, there is no generally accepted guideline for the treatment of the IORT of breast cancer patients. Consensus statement or guidelines from American Society of Therapeutic Radiation Oncology, European Society of Therapeutic Radiation Oncology, American Brachytherapy Society, or the American Society of Breast Surgeons are most generally accepted. Here are some eligibility criteria in different guidelines, including the age, histology, tumor size, tumor stage, margin, nodal status, estrogen receptor status and so on. Feel free to pause the video to have a look. So, that's all of some brief info about IORT. Every choice of option for the treatments have its pros and cons. One should always seek for the advice from their oncologist to make a correct decision. Thank you for watching.